My name is Dr. Jay Lim, consultant urologist, and welcome to another episode of Keeping It Simple series for common urological problems. Today we'll be talking about TURP, which stands for transurethral resection of the prostate. It is one of the commonest surgery that is performed by urologists all over the world to treat the condition known as BPH or benign prostatic hyperplasia, otherwise known as big prostate as we know it. Up to 50% of patients, older men in the world, experience some form of voiding discomfort when you reach the age of 50. That numbers continues to increase all the way up to 70% by the time we reach 70, and it continues to go on an upward trend too. Some of the symptoms experienced by men include voiding difficulty, slow stream, frequency, urgency, and waking up multiple times in the middle of the night. So the question is, does all BPH need to be treated by surgery? The good news is a lot of patients with these problems can be adequately managed either via lifestyle modification or medication. It is a small proportion of patients that doesn't do well with the above mentioned methods that surgery needs to be considered. So without further ado, let's get straight into TURP to understand a bit more what it really entails. So TURP stands for transurethral resection of the prostate. Like I said, it is commonly done for BPH. And so BPH can manifest in a variety of manner. Most commonly, patients come to me telling me they have problems with frequency. They are very, very urgent. They require to go to the toilet. They have very, very slow stream. They have UTI, and essentially they have blood in their urine as well. And they've also got having to go to the toilet in the middle of the night. So it's important to understand that this video here is not meant to replace a face-to-face consult with your urologist if you have all these problems. So some of the things that we're going to go through today are the overview of the anatomy, the procedure itself, how the stay of the surgery, how the recovery is going to be like, and the various complications that can occur, which is very, very important and can occur with any surgery. So we'll go straight into it. All these pictures that I have here today are of their respective copyrights that you can find in the internet. So on the pictures on the left, you will see that this is essentially anatomy of the kidney that we have over here. So these two things here are the kidney, and essentially what happens is the kidney basically makes urine, and the urine goes down this structure, the tubular structure called a ureter, and starts filling up in the bladder like this. And in a normal situation, we just void, ideally. So this is a generic picture that's not meant to show either male or female anatomy. And if anything else, this picture will probably be a bit more accurate to represent the female sex rather than the male. So what BPH occurs is as the urine actually starts filling up in the bladder and it tries to go up, as you can see, there's a fair bit of obstruction that is closing up the little narrow passage, and you start having drips and drips and drips and drips that come through. There are many ways that we can diagnose BPH, and there are many ways to treat BPH. Generally, the first time you see me, we'll go through a bit of your history and what we can do if we found to have BPH. The first step is usually through a combination of what we call lifestyle changes and lifestyle modification, things that you can perhaps do to make your symptoms somewhat bearable without the need for medications or surgery. Naturally, if you fall into those categories that will require a bit more help, then naturally, then we will try medications, and then when it fails again, that's when surgery comes. Before we get there, we need to diagnose surgery itself. Diagnose that you do actually have an obstructed prostate that's blocking out your urethra, the passage to the outside world from the bladder. So what we do is we'll do some form of imaging either via ultrasound or we put a cystoscope. So essentially what this picture right here is a view from a cystoscope. This is a camera that is put through the urethra. You go all the way up to have a look what's going on. You can see from the picture the black background is these are essentially your prostate. I've got a little structure here called the verumontana. Okay, it's supposed to be available. It is present in in males, and as you can see, this part of the organ
is protruding so much so that I've got a very little small channel that urine can comes out here. In the ideal world, what the channel should be is essentially a big fat channel like that you can actually allow urine to flow through. And the whole point of having a treatment for TURP, regardless of what kind of treatment you do, be it TURP, TUERP, or Resume, the whole goal is to reduce the obstruction, create a channel, possibly like that will allow urine to flow through a nice big channel that we see here. There's a few ways that you can do TURP. What do I mean a few ways is you can do it either under general anesthetic, which is a very common way, or you can do it under regional. A general anesthetics is essentially whereby you basically take, once you come into the theater, you take a nap, you go to sleep, you wake up in the ward, you have no idea what happens. Essentially, surgery is over. But it's not suitable for everybody because there are some people you need to have a very good cardiovascular system or state of the heart, and there's always a small risk of stroke and heart attack. Okay, a heart attack, what we call AMI. The second option is to do a regional anesthetic. So regional anesthetic is pretty much like what women go through. We put the anesthetist will basically put a numbing agent through the spine, and that will numb all the way from the umbilicus all the way down. It allows me to do surgery. The good thing about this is that it is a lot less strenuous on the heart in itself. You can actually stay awake. You can actually talk to me during the surgery and find out what's going on, how things are going, or you can have a little chat about things in life in general while the surgery is ongoing. We have, again, the kidney, and we have the bladder that actually comes here. So in a situation when you have BPH, instead of having nice big channels like this, you have a big prostate that is blocking everything from going out. Urine are stuck here, and you are unable to get it out to the toilet in time. The bladder itself becomes very unstable, and it causes a lot of downstream problems like overactive bladder syndrome that we can go through a bit later on. When you wake up in the ward, you will basically find yourself having a IDC, which is a rubbery tube that's put in down there. In that rubbery tube, there are two connections, one over here, and another one goes towards the other side. We're going to use a red color to draw it. What happens is that when the surgery is done, we will put a catheter which has two special openings, one going through in like that, water going through, clear water, and washes the bladder and the wound, and then basically comes straight out here to fill out the outflow, which is essentially going to be slightly pink in color. How long do you need to put this? This bag usually stays for a total for 2 days. And on the day after the surgery, what happens is I will basically come in the middle in the morning and essentially look at the color of this and decide. If I see a nice slightly pink color or a totally white color, everything is a-okay. And essentially what I'll do right there is basically I'll stop the inflow and I'll let you drink and eat normally, and essentially I'll continue to observe until the next day morning. If everything still remains nice and clean, I will remove the entire tube by taking it all out. So that by then you would have stayed 2 nights in the hospital, and you will be pretty much ready to go home after that. We come down to the stage of going home, or the recovery stage. Okay, this is the recovery stage whereby I discharge you. What do you expect, and how long should it last? Some of the things that you will need to understand during recovery is that you will be expected to see a bit of pink color urine. Okay, and how long does it last? It can last all the way up to 8 weeks. Okay. Then what are the other things that you can expect as well? A bit of smarting, a bit of pain when you void, and naturally a bit of a burning sensation. However, these are generally temporary, and you should be able to get rid of them after the first 2 or 3 days after you remove it. what do you need to be looking out for, and what are things that are of concern? Are things like red color urine that is very, very thick or very, very red. What I normally say is if you see a ketchup thickness or consistency color, no good. The other way to look at it is if you have red wine color as a urine that's so dark, these are not good signs. You need to inform us, and essentially we will tell you what to do. And there's a possibility that you may to come back to hospital to let us have a better look at what's going on. One of the common questions that I always have is, all right, doctor, I'm supposed to have pink color urine all the way to 6 to 8 weeks, but what's pink? And everybody's understanding of red and pink is very, very different. The easy way for us to remember this would be to look at perhaps a color like red color. Okay, what I generally tells my patient is a good way to look at it is essentially if you were to see somewhat pinkish and red, when is it something that you need to worry about? When is it something that you don't have to worry about? Is whether you can see the bottom of the fluid. After you void, you turn a look around, look at the toilet bowl. If you can see the bottom of the toilet bowl and some of the sediments which will come out from the surgery, everything is okay. However, if it's so red that you cannot see what's going on, and it's something that's obscuring your vision, probably not a good idea. And it's probably not a bad idea to give us a call and see how whether you need to come in for us to have a good look at you and make sure you are well before we move on in the recovery phase. With that, we pretty much covered the recovery phase of things, and the last section that is important for us to go through would be complications. Complication is a very, very important part of any counseling that you will need to go through. In an ideal situation, all surgery would be without complications. Everybody goes through the process in a straightforward manner, and we would not be here. But unfortunately, that doesn't happen. And it's important for you to understand what are the potential things that can happen to you. Bleeding, okay, is one thing that can certainly happen as far as surgery is concerned. Any form of surgery would requires incision, and if you need to incise, you will bleed. So bleeding for TURP is a common procedure. It's a common complication, and depending on the size of your prostate, there is a small chance that you will require some form of transfusion. However, the good news is generally it's less than 1%, and in my hands, I've only needed to transfuse a handful of patients that I can count with less than one hand in the hundreds of prostate that I've done. It is a small possibility, but certainly is down there. Okay. The second thing we need to cover is infection. Again, infection is something that can occur. As you can imagine, once I've, make a hole in the bladder right now, there are some areas that's very raw. And with urine, being urine, there's a chance that you can get into it and essentially get into an infected situation. Again, we will try very hard to avoid all these complications by giving you preoperative antibiotics, and if you need to, even some antibiotics to go home with. As with every surgery, once you have an open wound, it is something that can happen. It is not preventable. Unfortunately, it is a risk we have to take, a small risk for a long and sustained benefit that we have. Now, the following complications is what I call the series of R's that can occur. It's probably very important to certain people. The first R that we're going to talk about is retrograde ejaculation. So retrograde ejaculation will require me to just basically go through a bit of anatomy again. So again, this is the prostate that is down there. Okay. In ideal situation, in the normal situation, we have two sets of doors, okay? When you have a normal prostate and when you're sexually active, what happens is when you have sperm coming out, the two sets of doors act in conjunction, so much so that this set of doors on top closes while this one's open. The whole purpose is that so sperms go outward instead of going backwards. So this is what happens when you have a normal intact prostate. But when you have TURP done, what happens is that this whole area of the prostate has been destroyed, leaving you with a big cavity like this. And as a result, all these doors that we talked about would not be there anymore. So during ejaculation, or when you're sexually active, instead of the sperm going through downwards, there's a chance that it will go back upwards into the bladder itself and mixes with the urine that's existing there. What does it mean for people who have TURP and are sexually active? In short, and this is from the literature and for people that have undergone TURP, it doesn't actually change anything. What do I mean? The sexual pleasure derived from intercourse will not change. However, you will be expected to see slightly less ejaculate, or you may not have any ejaculation at all. What you tend to see is the first void after you finish intercourse, you will be expected to see a bit of a cloudy urine. And essentially that's where the ejaculate went through and you just got to void out with the urine itself. So if you are someone in your 50s and 60s who basically have completed your childbearing career and you're not looking to have any more, then essentially this surgery would be suitable for you. However, if you are someone that is basically still of a childbearing age and essentially are looking at having a family, this is not a surgery, definitely not the right surgery for you. Speak to your urologist and they might be able to offer you some other alternatives which are available and can treat BPH symptoms. Okay, and we now go to the next R, which is regrowth. So as you can see from here, I've left a bit of prostate tissue over here as we speak. And over as days go by, okay, as we go on to move on to in life, there will always be a bit of prostates that regrow. Okay, regrowth occurs again, the red colors one and regrowth, and they can grow back into the original space that they were, causing a bit of obstruction all over again. When does it happen? How does it happen? It happens usually around 10 to 15 years after the initial surgery, and it's not something that should happen in the next year or so. If it does indeed happen, it is probably because you had a stricture, but that's another thing altogether. But for regrowth, it is when you had initial TURP, and after a long period of time, the prostatic tissues grow back again. You've been very good and healthy in life. Prostate tissues are very happy. The prostate wants to grow back to its original size and cause a bit of blockage again. The good news is most of my patients that I deal with, 60% of them would only need to have one surgery in their lifetime, and that should be able to last them. I have had patients, a small percentage, that require at most 2 surgery, and a very even smaller number that has 3 surgery, and those are few and far in between. For most other patients, generally you'll be expected to have 1 surgery, and essentially that will be the end of your need to involve a urologist as far as prostate BPH is concerned. There's one more that I need to go. I'm sorry for that. Is the retention. Retention is also another possible complications that can occur. So as we've basically removed a lot of prostatic tissue, there are a lot of red areas, and on day 2 or day 3, POD3, when I remove the catheter and everything goes back, you go home and it's a nice little flow that you have. But as the day go by, you will find that the stream gets smaller and smaller, and we're talking about the same day. Morning you remove, by evening you can't pee again. This is certainly not regrowth, but what happens is that swelling occurs. And as with any surgery, swelling can occur. And what it then causes is that you narrow out the outlet that you have in the prostate, and it prevents you from coming out, and you have a big bladder, you have pain, and essentially you go into retention. What do you do for this in those situations? In those situations, you've got to let us know. We'll actually give you a contact number for you to contact us, and you might basically require to have another IDC reinserted. When does it happen? It happens in the first 24 hours of removal. So this is a period of time that you need to worry about. Unfortunately, it comes as part of the surgery itself, a little thing that you need to note as you go back. But Singapore is a very, very small place. If there's a need to, we can easily get you back to the clinic or to any hospital to put in a indwelling catheter back again. Okay. So with that, I pretty much now finally covered the whole process of TURP. I hope I was able to answer your questions or any of the queries that you may have. Again, I reiterate that this adjunct is meant to be an adjunct for patients who have seen me face-to-face either earlier, before, and would like to have a revision of rehash of what TURP involves. For those that had family members who unfortunately are unable to come with your family member, would like to find out more, this is potentially one of those resources that you can look at. I'm very happy for patients who've never seen me before to have a look at all this information, and I hope that it answers some of your questions. But certainly, as I reiterated, this video is not a replacement for a face-to-face consult. If you have any of the above mentioned problems that we went through earlier, I suggest you go and see your urologist and have a discussion of what needs to be done for you. Once again, thank you very much for your time, and we will see you soon again. Bye.